I'm really delighted to start our 2024-2025 session of the Women's Health Seminar Series with Dr. Junie Paula Warrington. I've heard her speak before. You're in for a treat. And the title of her talk is Modeling Neurovascular-Cognitive Complications After Preeclampsia-like Conditions in Rodents. But first, I would like to do a land acknowledgement. I want to recognize that we live, work, play, and participate in a community on the unceded, ceded, and traditional grounds of the 630 First Nations here in Canada, each of which possess their own unique traditions and history on this land that we now refer to as Canada. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action and the United Nations Declaration on the Rights of Indigenous Peoples. In all of our work, we're committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I'm joining you from Toronto, which is covered by Toronto Purchase number 13 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich the city. Many of our members live in Vancouver, which is also part of the unceded homelands of the Coast Salish peoples, the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. However, I'm well aware that many of you are joining from other regions in North America and beyond, and I encourage you to use the chat to inform us of where of the lands of which you dwell. We are the Women's Health Research Cluster. You might not know who we are, so we give a little bit of an overview. We currently have over 750 members across 32 countries, and we come from all walks of life. We have run a number of events, including the seminar series. We have podcasts, we have blogs. Please, if you want to write a blog, please let us know. There's a place on the website to let us know. If you want to support us, please feel free to support us. We're actually right in the middle of changing our website, so that should come up very soon. But we're very pleased to be here to bring you content on women's health. So I'm going to stop sharing so that Dr. Paula Warrington can share her screen, and I will read her bio while she does this. Dr. Junie Paula Warrington is an associate professor in the Department of Neurology and associate director of the PhD program in Neuroscience at the University of Mississippi Medical Center. She received a PhD in neuroscience from the University of Oklahoma Health Sciences Center, and she's co-authored over 40 peer-reviewed manuscripts and editorials. She's been continuously funded from fellowships from the American Heart Association, and she also received a very prestigious K99 R00 Pathway. I don't know if you say OO or double O, I'm not sure, to Independence grant from NIH. And she also received a supplement to work on the work that she'll be talking about today, and was recently rewarded an NIH R57 award. I was lucky enough to meet Paula at a workshop that NIH hosted last year on long-term effects of pregnancy on the body, and we had a really good 2-day workshop. I'm looking forward to what NIH does with that workshop, and that was organized, I think, by Institute of Aging, National Institute of Aging. Dr. Warrington also serves as co-editor-in-chief of the Journal of Neuroscience Research and a consulting editor of American Journal of Physiology, I think it is, Heart. And she served as a digital media editor of Stroke. And she's served as guest editor, many special issues. She served on multiple committees. And the best part of their job, she says, is mentoring. Her ultimate goal is to change the landscape of academia by making it a more welcome, supportive environment for future scientists. Oh, I hope she's successful. It's so important. And the last thing as many of you may know, I like to ask people what their fun fact is. I'm hoping they're going to tell me that they're, were originally a rock star or something. But Dr. Warrington has 16 siblings. That is a pretty fun fact and an amazing fact. And she's from the beautiful nature isle of the Caribbean, Dominica, and elle parlait en français un peu.
Oui.
Take it away.
Merci beaucoup. All right, well, thank you so much, Dr. Galea, for this invitation. It's always an honor to present the updates of our work and our research that we're doing. Hopefully, we'll be able to garner additional interest that will secure us our funding, specifically at the R01 level. That is our ultimate priority and goal right now. So what I've put together for today is a little bit of some of the work that we've been doing over the years that try to give us an idea of the postpartum sequelae that follows pregnancies that are complicated by preeclampsia and other hypertensive disorders of pregnancy. It is not a complete story, but I try to put different aspects that focus on different rodent models that we have used over the years. So one of the reasons why I became interested in this line of research is because as of last year, there were additional studies previously, but last year's statistics by the Alzheimer's Association showed that twice as many women, that's 1 in every 5 women, as opposed to 1 in every 10 men, have a lifetime risk for Alzheimer's disease at age 45. Now, 45 is pretty young, and we can see that already at this young age, there is an increased risk for women to develop Alzheimer's disease, which kind of takes away that long debate about whether or not it's because women have this extended lifespan that her risk is increased. So with that, I thought maybe there's something unique about women that make us more susceptible to Alzheimer's disease. So my question was, could pregnancy and specifically how complications of pregnancy increase the risk for cerebral abnormalities that manifest as neurodegeneration and dementia-like symptoms years after index pregnancy? And so one of the areas that disorders of pregnancies that I'm interested in is preeclampsia. And for those of you who are not aware, it is a hypertensive disorder of pregnancy. It is usually diagnosed during pregnancy, although there is an increasing prevalence of women or incidence of women who develop postpartum preeclampsia. But for the most part, the vast majority of women develop preeclampsia during pregnancy, generally after the 20th week of gestation. She presents with an increased blood pressure, generally over 140, over 90 millimeters of mercury, with any one of the symptoms listed here. In the past, it would have had to include proteinuria. However, with the revised guidelines, she could be diagnosed with preeclampsia if she has the hypertension, along with visual or cerebral symptoms, low platelet counts, renal insufficiency, impaired liver function. And currently, we know that it affects about 2 to 8% of pregnancies in the United States, and it varies significantly depending on our demographic group as well. It is responsible for about 50,000 maternal deaths and over 500,000 fetal deaths worldwide. Now, what we know that's quite interesting is that about 40% of preeclampsia or eclampsia-related deaths are due to cerebrovascular events, with the vast majority being attributed to stroke and edema. There is one study that says that this number is up to 70%. These patients present with neurological symptoms that include headaches, blurred vision, nausea, drowsiness, and if it does progress to seizures, then she is diagnosed with eclampsia. We also know that preeclampsia patients have a high risk of developing stroke during pregnancy, and the risk is also increased postpartum with an earlier incidence of stroke in the postpartum period as well. So, as I mentioned, eclampsia, if you look at the word pre-eclampsia, it means preceding eclampsia. Although it is rare, it has devastating effects on both the mom and the developing fetus. It affects about 1 in 200 women would develop eclampsia in developing countries, so that's about 0.5%. However, it accounts for 13% of all maternal deaths worldwide, so it's a serious condition. It's the highest predictor of postpartum acute cerebrovascular disease as well. So what are some of the cerebrovascular disorders that are observed in women with preeclampsia or eclampsia? One of the most common is PRES, posterior reversible encephalopathy syndrome, that is usually characterized by vasogenic edema and blood-brain barrier breakdown. It tends to occur primarily in the occipital cortex or the posterior region, thus the name, although it has been shown to affect other regions of the brain as well. It can result in visual disturbances and even cortical blindness. And it results in coma, status epilepticus, or seizures, and intracerebral hemorrhage. So as you can see, the cerebral vasculature is a significant predictor of patients who would go on to have seizures. So about 98% of women with eclampsia have been shown to have PRES on imaging. The other cerebrovascular abnormality that is seen in preeclampsia patient is reversible cerebrovascular constriction syndrome, and that is usually described as that sausage-like phenotype of the blood vessels. As you can see here in this angiogram, you see this area of local constriction, which does lead to reduced blood flow to the subsequent regions where this particular artery or blood vessel would supply. So it has been described in patients as a sudden severe thunderclap headache. It just comes on really suddenly. And it causes vasospasm of the arteries, most of which are associated with the circle of Willis. And it's associated with ischemic stroke and other subarachnoid hemorrhage type stuff. And what is very interesting is that the majority of these PRES and RCVS occur in the postpartum period, so the early postpartum period, and sometimes in women with no prior complication of preeclampsia, although the vast majority do have preeclampsia preceding that diagnosis. So here is a case study of a 32-year-old woman who presented to the clinic 4 days postpartum. Her primary complaints were hypertension and severe headache. Here are some imaging that were taken. So this is a CT scan, and you can see that there is an area of intracerebral hemorrhage shown here and herniation of the cerebral cortex. So you see this displacement of the ventricles, which are usually central. When the angiogram was done, you can see these areas of local vasoconstriction, as we mentioned before, which is one of the primary characteristics of RCVS. And so this patient was diagnosed with RCVS and received, I believe this patient did not survive the diagnosis or the RCVS in pregnancy. So what might be contributing to the cerebrovascular abnormalities in these women with preeclampsia? We know that cerebral blood flow is a tightly regulated process. There are multiple mechanisms that have been shown to contribute to cerebral blood flow regulation. These include myogenic, which is the constriction of vessels, mainly through the smooth muscle cells. We could have neurogenic. This is done through nerve innervation, direct innervation of the blood vessels. We have metabolic, where changes in carbon dioxide, oxygen, or even protons could impact cerebral blood flow regulation. And then we have endothelial derived factors that have been shown to directly control cerebral blood pressure of perfusion pressure. So one of the areas that we have focused on is the myogenic mechanism for controlling cerebral blood flow. And as I mentioned, it's an intrinsic property of the blood vessels to constrict when you have increases in blood pressure. So on the x-axis are different blood pressure measurement, and then we see changes in cerebral blood flow on the y-axis. So at the lower levels, from about 0 to 50 millimeters of mercury, there is this passive dilation of vessels. And then within the physiological range of blood pressure, which is considered to be 50 to 150, we see that blood flow is kept relatively constant. And this is important because if it is not regulated, then you could have rupture of the blood-brain barrier, and you can have the hemorrhages that we have heard about occurring in patients with preeclampsia. Beyond this point, however, there's what's called forced dilatation, which contributes to vasogenic edema, which is the actual disruption of the blood-brain barrier. And we see a lot of the symptoms that women with preeclampsia would present with. There have been some debate as to whether or not the range of autoregulation is this wide. And there is one paper that posited that it is actually smaller. So only about 18 millimeters of mercury changes would lead to that regulated blood flow. And beyond these blood pressure ranges, then you have an increase or a decrease. So that's something that is constantly being debated. So this nice study here, I really like to present because it does show, in this case, dynamic cerebral autoregulation. And this is measured where a woman is asked to do a maneuver that will cause drastic increases in blood pressure. And then she would be wearing a Doppler, and you can measure changes in cerebral blood flow velocity in response. So what we see here, and we have several groups. That's why I like this. Almost all of the different hypertensive disorders of pregnancies are represented in this graph. Our controls are normal pregnant women. Again, they're asked to do the maneuver, and what happens is that there is this really quick rise in cerebral blood flow velocity, but it returns within seconds back to baseline with a slight overshoot. When we look at the patients with preeclampsia, we see that they do have the response. Sorry, this is gestational hypertension. We see this response, although there is already some slight impairment in the ability to return back to baseline cerebral blood flow velocities. Here are our chronic hypertensive patients. These are people who had hypertension before they became pregnant, but did not develop any additional complications. And we see again that even further impairment in their cerebral blood flow autoregulation. And our preeclampsia patients are pretty close to that. And what was really striking is that patients with superimposed preeclampsia have the worst phenotype. These are women with chronic hypertension before they got pregnant, and then they develop symptoms of preeclampsia during pregnancy. And we see that they have a significant impairment in their ability to autoregulate cerebral blood flow, which of course is a significant risk factor for stroke and PRES and the RCVS that we talked about, and even seizures. This was then quantified as an autoregulatory index, and we can see, just as we show here, that the superimposed preeclampsia patients have the worst autoregulatory index, showing that they do have impaired cerebrovascular function. So how do we study these underlying mechanisms? Well, our lab focuses on preclinical animal models. We do not have any patient studies currently, but we do have plans in the future. And so we have a wide array of animal models that have been described in the literature that would mimic different characteristics of hypertensive disorders of pregnancy. Our lab uses the surgical approach, and I will talk a little bit more about that, where we induce a preeclampsia-like phenotype. This model has been reported in rats, in mice, in sheep, and in monkeys. We have diet-induced. There is a group, Dr. Sapola's group, who uses the high cholesterol diet administered early during gestation as a model of preeclampsia. We have spontaneous animal models. The blood pressure high 5 mouse has been described as a spontaneous model, the dorsal sensitive junior rat, and the African green monkey, although there's not been a lot of beyond abstracts published work with this model. We have hypoxia, we have inflammatory cytokines to kind of tease apart the different mechanisms, genetic models, and then there is a group here at UMMC where adaptive transfer of immune cells from preeclampsia patients are introduced into normal pregnant rats to induce preeclampsia-like symptoms. So there's a wide array of models available to test our hypotheses. For us, what we do, we have an interest in understanding mechanisms for eclampsia as well. So what we'll do is we'll select one of these preeclampsia model, and then will induce seizures. It's not a perfect model because it's not a spontaneous seizure model, but we're able to look at the sensitivity to seizures in a preeclampsia model versus a normal pregnant model. So we do think that there is some merit to our models that we use. So as I mentioned, we use the surgical model most commonly. And the reason we use that is because we know that during a healthy pregnancy, there are fetally derived cells that migrate. They're called cytotrophoblasts, and they invade the maternal uterine spinal arteries. And what they will do is they will replace the endothelial cells, and that will cause a remodeling of the vessels so that they become enlarged, and there is increased flow to the developing placenta and fetal unit. In preeclampsia, this process is thought to be incomplete. So there is a minimum invasion and migration of these cells. However, they do not penetrate deep enough to cause this remodeling. And so the blood vessels remain constricted and narrow. And then we have reduced blood flow to the developing placenta and fetus. It causes hypoxia. And then we have a lot of the maternal symptoms that we see in the women. So Dr. Granger, who was one of my postdoc mentors, developed this model in the rat, and we induced that by placing silver clips of known diameters on both branches of the uterine vessels between the ovary and the first pup. And then to account for compensatory flow, we also placed a silver clip on the abdominal aorta below the renal arteries and above the iliac bifurcation shown here. So with this model, we've been able to show that there are indeed features of cerebrovascular abnormalities. So one of the studies that was done before I came to the lab was where isolated segments of the middle cerebral arteries were taken out and were subjected to myogenic response ex vivo. And we can see here that changes in intraluminal pressure normally induces an increase in vessel tone. So we see that in our control non-pregnant animals and as well as our pregnant control animals. When we look at our animals that were subjected to this procedure or reduced uterine perfusion pressure RUP model, we see that this increase in tone is completely abolished. So they're not able to constrict with these increases in intraluminal pressure, demonstrating some impairments in cerebrovascular function. When I came to the lab, I was tasked with checking in vivo to see if there were any abnormalities with the cerebrovascular response. So to do that, we used time-pregnant rats. These are Sprague Dawley rats. And then we subjected them to increases and phenylephrine, which we know increases blood pressure. So we did it in a controlled fashion so that we can measure changes in cerebral blood flow using laser Doppler flowmetry at specific blood pressure time or units. We continuously measured blood pressure, the exhaled carbon dioxide, and the body temperature, and we maintained the arterial carbon dioxide to about 35 millimeters of mercury because we know that CO2 can cause vasodilation. And so what we show here we're showing our normal pregnant animals. We're from 100 millimeters of mercury. We're saying that about 160 is physiological, although it's already high. And we see that that was able to induce about 20 to 30% increase in cerebral blood flow in our normal pregnant animals. When we look at our RUP animals that we termed here placental ischemic animals, we see that this increases about 4 to 5-fold within the same blood pressure range, again showing that there is impaired cerebrovascular function, potentially forced dilatation of the vessels here. So as I mentioned, this model has been characterized tremendously over the years. A lot of the studies were focused on kidney function, etc. And so over the years, it's been shown that just like the preeclampsia patient, there's this hypertension, there's reduced placental perfusion, there's intrauterine growth restriction in some of the offspring, proteinuria in some. There's an increase in inflammatory cytokines, an increase in anti-angiogenic factors such as SFLT1, and we also showed that there was an increase. There was a cerebrovascular abnormalities. I'm not showing this here, but we also show that there's some retinal vascular abnormalities as well. But we had not yet characterized the postpartum, phenotype of these animals. So Dr. Nina Pauw, pictured here, visited us from the Netherlands, and she was interested in studying some of the renal changes following a pregnancy complicated by a RUP. So what we did is received our time-pregnant animals. They were subjected to a sham or RUP surgery. They were allowed to deliver, and 8 weeks postpartum, we collected tissues, measured blood pressure, etc. So during pregnancy, the animals had an increase in mean arterial pressure, but you can see at 8 weeks, there was no longer a difference, which demonstrates, just like we see in a lot of our preeclampsia patient where blood pressure returns to normal, we saw that in our animals. They were no longer different. There was a slight decrease in their body weight, and there was a slight increase, although not significant, in the urinary albumin excretion in these animals. So what I did is I took some of the brains of the moms, and then I wanted to see whether or not there were any changes in neuroinflammation markers. So we took a fishing approach where we use a multiplex kit with multiple cytokines and chemokines. And then we measured the levels in both the posterior cortex and our hippocampus. We also did some brain water content measurements, which is a crude marker for cerebral edema. And we did see that there was a significant increase in the animals that were subjected to RUP during pregnancy in terms of their cortical water content compared to the shams. But what was quite striking is that there was a significant increase in multiple pro-inflammatory cytokines in that same region, which was accompanied by an increase in some of our anti-inflammatory cytokines, which we know increased to try to restore homeostasis. In the hippocampus, it was not as exciting. We had probably two cytokines that were changed, and they were anti-inflammatory cytokines. We're not sure why the cortex is more susceptible, but so far, this is what a lot of our studies are showing. But we wanted to look to see if the glial cells that are known to be the primary producers of cytokines were changed in our model. So we first look at astrocytes, and we used immunofluorescence staining. We also did some Western blot as well, but here I'm just showing the immunofluorescence staining in the posterior cortex and the hippocampus. And we found that there was an increase in the density of astrocytes in both regions, but there was only an increase in the area covered by astrocytes in our cortex. So this tend to demonstrate that there might be some cytotoxic edema that might be occurring. We know cytotoxic edema occurs when you have increased water in the cells themselves. And you can see it here in the image where the size of the cells are increased. So we had these increases in pro-inflammatory cytokines. We have some evidence that the astrocytes might be activated. So we were also interested in looking at microglia activation, which are the other cell type that are producers of cytokines or inflammation. So again, we measured using IBA1, which is a marker for both macrophages and microglia, but primary microglia in the brain. And then we counted like we did before. And so we found that contrary to our hypothesis, there was a decrease in the number of these cells in the cortical region and no change in the hippocampus. What we think is happening here is that with sustained or chronic inflammation, these cells might be undergoing apoptosis, and then we have reduced numbers, but we have not tested that directly. So right now we just have an observation that it's decreased in the RUP exposed moms. So even though the numbers were different, we wanted to see if the remaining microglia had any evidence of activation, different activation status. And we found in the literature that you can look phenotypically at the cell morphology and determine what type they are. So normally a resting surveying microglia would have this small cell body, and they would have these processes that tend to be long and thin. As they increase in the activation status, you see that the cell body size increases, the width of the processes increase, and they shorten as well to the point where they become phagocytic or amoeboidal, where they are the most activated type. So we had a summer student at the time who we tasked with counting and characterizing all of the microglia that were visible within the regions of interest. And what we found is that in the posterior cortex, we had a significant increase in the proportion of type 4, our most phagocytic type. So although we have fewer microglia, we have an increase in the number of these remaining microglia that are at the phagocytic stage, demonstrating increased neuroinflammation. In the hippocampus, the vast differences were observed in the type 3, which are the ones that are being activated, but potentially they're able to then not progress to the phagocytic stage. So we have a few here. So to summarize, we have this increase in pro-inflammatory elements, increase in astrocyte activation, microglia activation. The next potential step could be that these pro-inflammatory environment could induce neuronal death, which is one of our hallmark features of neurodegeneration and Alzheimer's disease. Sadly, we have not pursued that yet, but it's something that is on our radar to do. And in this cohort of animals, we also did not explore whether they had any signs of cognitive impairment. And that's something that is of active and ongoing interest in the lab with our mouse or mice studies. So moving along, I'm going to shift to a different animal model of preeclampsia. So here we're asking whether or not there are long-term neurological complications following pregnancy complicated by hypertensive disorders of pregnancy. And you've seen that. This is some of the epidemiological evidence that shows that women with a history of preeclampsia have a higher risk of mortality from Alzheimer's disease and stroke. We have evidence that women with a history of preeclampsia have a higher incidence of vascular dementia. So if you look at this graph here, we see in blue our vascular dementia hazard ratios. It is highest in women with a history of preeclampsia, and not so much those with Alzheimer's disease. So it seems that women with a history of preeclampsia are more likely to have vascular dementia as opposed to Alzheimer's disease. Essentially is what this particular study showed. They did include patients with preeclampsia, eclampsia, or HELLP syndrome in this particular model. What was also interesting is that women with a history of preeclampsia who had a small for gestational age infant, which is one of the complications of preeclampsia, they had a 7-fold increase in their vascular dementia risk as opposed to those with normal birth weight, which was even less. And again, we don't see that same pattern for Alzheimer's disease risk. So it seems that a history of preeclampsia, we know preeclampsia itself has a strong vascular risk and a vascular component. And we see that that also extends in the postpartum period as well, where we have vascular dementia being potentially the most common type of dementia that is seen in these women. Another interesting observation in patients with a history of preeclampsia is that they have an increased burden of what are known as white matter lesions. These are considered to be abnormalities that are seen on imaging, like MRI imaging, and they are predictors of vascular damage. And here in this particular study, we see that women with a history of preeclampsia have a high burden of white matter lesions, with the vast majority of them being in the frontal lobe. And then a study that was done by UMMC faculty showed that there was an increase in white matter lesions in the temporal lobe, which is the area that houses the hippocampus. So again, strong evidence that there might be some vascular damage later on. And they show that the severity of these white matter microstructure correlated positively with the time post-pregnancy. So the further along you were in post-pregnancy, the more severe this white matter lesion were in the patients. So all of these are very interesting. And something that I want to pose probably to Dr. Galea or others is, that we see that during pregnancy, we have a high burden of vascular abnormalities that seem to be confined to the posterior cortex, a lot of occipital, parietal regions. And then when we go into the postpartum period, we see that a lot of the white matter lesions seem to be focused in the frontal lobe. And to me, I feel like this is something that is very difficult to explain, and why there's a switch in the areas of the brain that are affected is something that I would really love for somebody to look into. One of the things I could think about is probably just, we have different blood vessels that feed the posterior cortex as opposed to the anterior cortex. And so maybe some of those are more susceptible to different factors. But it is an interesting area that I hope that somebody, probably us in the future, could try to address and figure out why that happens. And so I think this might be the last part I'll have time to cover, but as I mentioned, there are some spontaneous animal models that have been described in the literature. So these animals tend to have hypertension before they get pregnant, so they're more of a model of superimposed preeclampsia, because they are hypertensive before pregnancy and then they develop preeclampsia-like symptoms during pregnancy. So we have some data for the BPH5 mice that has not been published. And then we have some that from the dorsal sensitive junior rats that we have had the privilege of working with Dr. Sassa and Dr. Garrett to complete over the years. So one of the key findings was that the dorsal sensitive rats, pregnant rats, had evidence of blood-brain barrier abnormalities. So here, the controls are the Sprague Dolly animals. So these are the animals that here were not pregnant. We see intact tight junctions that are formed by the endothelial cells. Trust me, I hope you can see them. In our Sprague Dolly pregnant, these are our pregnant controls. We see that they are also intact here. When we go to the dorsal sensitive junior rat model, we see that they already in the virgins, again, they are hypertensive, and we know hypertension does cause abnormalities at the blood-brain barrier. We already see that there's a little bit of separation at the tight junction. These are done with electron microscopy. When we looked at our pregnant animals, we can see that there's a disruption right here. And these were quantified, and there was a significant increase in the disruption of the tight junctions in the pregnant superimposed pregnancy model, the dorsal sensitive rat. So I was able to collect some of the brains from the animals in the postpartum period. Again, when I get brains from people, it's very hard for me to control, the different things that happen to them up until that point. And so most of the times I just have tissues and I have to do the best with what I have. So we were thinking about doing similar, analysis as we did in the rat, where we would stain with microglia to see if there were increases in microglia activation and if there were any evidence of neuroinflammation. Now, what caught my attention when I was surveying the tissue section was that the PL vessels, so these are the vessels that are on the surface of the brain below the dura, they are surrounded by CSF. I noticed that there were a set of cells that were lining these vessels that were IBA1 positive, which are normal microglia cells. And I had not seen that reported anywhere else. So I took as many images as I could from all the animals that we had, try to find these they were in the posterior region, so I suspect it could be from the posterior cerebral arteries. And we found when we quantify them, again, trying to be creative and try to figure out how do we quantify them. So we decided to do a parameter. So we just did the length of the vessel. And then we counted the number of these cells that were associated with that. And we did that in all of the animals. And you can see that compared to our Sprague-Dawley controls, there was a significant increase in the density of these cells in the postpartum or prior pregnant and doll-sensitive rats. And that was seen both in the virgin as well as in the postpartum prior pregnant animals. When we look at the distance, so what we did is we tried to, use the length measurement to look at the distance between each of the cells. We see that the distance was reduced. Now, this was a little bit hard to interpret without any additional functional data, but it seemed to me that this was an additional layer of potential protection of these vessels that have been subjected to this increase in blood pressure and blood flow chronically, but that is to be determined. So again, with limited resources, we decided to just go try to characterize these cells. So one of the first things that we wanted to see is whether or not they were part of the glia limitans. And for those of you who are not very familiar, there is a barrier between the CSF. So as I mentioned, in the arachnoid space here, there's CSF that bathes this region. And this is the brain, parenchyma. So there's a surface of cells, these are GFAP positive, that line that and forms an additional barrier between the CSF and the brain. And what we found is that these cells were not part of that. They were actually outside of the glia limitans. And we can see that in many different images. This is, just giving a little bit of anatomy here. And then we decided to stain to see if they were antigen presenting, because we know that, if there's an infection or if there is, some need for an inflammation response, they tend to express major histocompatibility complex. Here we're looking at type 2. And we found that there were several of them that did express these MHC2 antibody. We also noticed that they were of different morphology as well. Some were rounded or amoeboidal, some were a little longer, and then some, formed like Peter-like cells. So still doesn't tell us a lot about what they're doing, but we thought it was interesting. When we quantify the number of these cells, again, just like we showed before, there's an increase in the density of the cells around the blood vessel, but there was also an increase in the doll cell-sensitive rats for those that were antigen presenting. And then when we looked at the microglial cells that are antigen presenting, we see that again, it's increased in the doll cell-sensitive rat. So taken together, it seems like there are these cells that we think could be surveying the CSF and responding to this chronic inflammation, which we have not measured in these animals. We have not looked at their cytokine levels, but we can hypothesize that it probably is increased in these animals. or it could be playing a protective role as a compensation to the increased intraluminal pressure that they see. And so for the sake of time, we're going to end here, but we have studies in our mice that show that in the postpartum period, they do have some spatial learning impairments. We've shown that they have some memory impairments when we look at, well, these are the ones that are subjected to seizures during pregnancy. And then they have some lower or reduced perfusion of the brain. And so we have very interesting results that we hope to explore further to understand what is contributing to these long-term postpartum changes in the mice and or rats that are exposed to hypertensive disorders of pregnancy. One interesting thing that we found was that there was an increase in tau. This is total tau, and A beta 42 in the mice that were subjected to seizures during pregnancy. So this would be our eclampsia-like animals. And that we also showed that the concentration of tau was positively correlated to their performance in the Barnes maze. So the ones who performed worse had a higher tau. And we also showed that the ones that had the highest A beta 42 had the lowest prefrontal cortical perfusion. So we have this nice relationship, and we're hoping to explore these data much further with a wonderful group of trainees who have gone through the lab over the years and our current lab members. None of this would be possible without them. And I am grateful to our funding sources. And at this time, also, thank you for your attention. And for the interest of time, we'll stop here, but I'm happy to answer questions in more detail if we have time for the stuff that I kind of skipped over.
I think that was my Fitbit's fault, but my Fitbit's fault. It was 4 minutes slow. How does that happen? Thank you very much. That was an amazing talk. You covered a lot, Dr. Warrington, and I'm sure there's going to be questions. I have some, but for those of you online now, if you don't mind showing a little bit of emojis so that we know that you're around. Of course, I have this new view, so I can't see everybody.
Can I stop sharing my screen so I can
You
see people?
can stop
Okay,
sharing your screen. Yes, you can. You're always going to get that one person who will ask,
to go back to a slide. Okay.
whatever, it'll be fine. So now I can't see people. So if people are, so let me know if there's anybody that wants, maybe Bonnie can let me know if there's somebody that has a question, but please put your question in the chat. Otherwise, I'm going to ask my questions, and I have no idea why it goes from posterior to anterior. You asked that question
Mhm.
yourself, and it's really interesting. So I had a little bit of question about timing there. But I wanted to ask you something. I wanted to ask two things first. One is something that kind of blew my mind after a while, and it shouldn't, after all these years of being in, women's health research. And Gabriella, I'll get to just in a second. That there's heterogeneity um, in preeclampsia. We say these words like menopause or preeclampsia or pregnancy like it's one thing. And it's taken me until, this long to hear that there's lots of preeclampsia, right? Like lots of different, and that suggests, like you had those different mechanistic pathways. It suggests that, you can get to preeclampsia through different.
Right. I think there was a study that I did not include that focused on stroke, and they stratified their data as well to look at, women with preeclampsia versus gestational hypertension versus
Right.
superimposed preeclampsia.
Yes.
And you can see that the risk is different for
Yes. I
all
was
of
just
these
that was
different
my second
subgroups.
question. Yeah, was
Yeah.
do you see like have the studies actually not probably not very many, but I don't
Not
want to
a
speak for
lot,
you.
because the thing is,
Yeah,
because of the rates are not very high,
true.
when you stratify, you lose
Yeah.
power. So
Yeah.
sometimes I think I remember reviewing a paper and I was like, even though it's low number, please look.
Yeah.
Because
Well,
I think it's informative. You can say that
yes,
it's underpowered. If you see a
yeah,
nice trend, it
yeah,
kind of gives you
exactly.
an idea of what might be going on. So,
Exactly. And that's one of my least favorite excuses. I don't have the power. I mean, at least show us the data so we can see is what direction is it going, and is
yeah.
it going in a profound way, because that could actually increase your power rather than decrease it. Gabriella, you had a question. Do you want to ask it, or do you want, we can see it.
Uh, yes. Hi.
Hi.
Thank you so much for a very informative presentation. Yeah, so a little bit like farther back before the preeclampsia happens, what can cause like this hypertension and high blood pressure?
So that's one of the million-dollar questions that have been asked a
Okay, I
lot.
see.
So there's this idea that pregnancy is a stress test for women, in that, there's some underlying vascular phenotype that is not clinically obvious.
Mhm.
And then when the woman gets pregnant, there's so many things that changes with pregnancy. A lot of hemodynamic changes happen, physiological changes. You have cardiac output going up, you have plasma volume going up. There's a lot of strain on mom. And so a lot of researchers tend to think that this stress of pregnancy reveals the underlying symptoms. And so the mom develops this hypertension. But there are lots of hypotheses. We're biased. We think a lot of it is vasculature, but there's also the inflammation as well. We also know that, when a fetus is growing, it's a foreign body. So our immune system is kind of reduced or dampened, so that, there's no rejection of the fetus. And so we know that there is a high likelihood for other complications because of that. And so we know that pro-inflammatory cytokines go up. Pro-inflammatory cytokines, if you inject in a pregnant animal, can have small increases in blood pressure. So there's a lot of different reasons or different mechanisms that could be contributing to this onset of hypertension in pregnancy. We know that preeclampsia is also a syndrome as well. So it may not be the same from one mom to the other, although there could be something that we haven't discovered yet that links all of us, not us, but all the women with preeclampsia, that might be common, but we do not have that common factor yet.
I have a
Thank you so much.
Thank you, Gabriella, for your question. I have a follow-up on that. When you say that, it could be, obviously it's linked to inflammation, is there any work that's been done on fetal sex? So if you're pregnant with a
Hmm.
male, that should, be more of an inflammatory challenge to the mother.
Yeah,
And so,
so that is a good question. I have not explored in depth. I do know that male offspring tend to have worse outcome if
no,
they're
interesting.
exposed to preeclampsia.
Yeah,
But in terms of whether or not fetal
yeah.
sex, like the onset of
Increase it.
preeclampsia
Yeah,
is higher in a male pregnancy.
yeah. Versus,
I have not
um,
looked. That's something I definitely will have to look into. I have not checked. And we have
and
the ability to do that, to look at the sex ratio of our offspring as well, to see is
yes, true.
there something that is unique. Do we have worse phenotype
Hmm.
in moms with a higher percentage of males versus females? With the
Hmm.
mice and rats, it's a little more complex, but that's a great question, something I'll have to look into.
And do you find, I want to ask a question about the hippocampus, but I'll try to
I know,
avoid
please
spending
do,
time there. But
please
also ask you another observation that I've had and other people have had is that there's a lot more attention paid to pregnancies rather than postpartum. What happens to the mother postpartum, or what happens to the birthing parent? Do you in your own work with preeclampsia, have you found something very similar, like that you see more work during pregnancy rather than postpartum?
Oh, for sure. The thing is that, I think,
It resolves, right?
right, yeah.
This
So
idea that
I'm
it
trying to think about
resolves.
10 years ago. So
Yeah,
everybody thought, you deliver the
yeah,
baby, mom is
yeah,
cured. There's no longer any risk. It's just now there's a
yeah.
lot more epidemiological studies that have been following women and see these changes. So now I think there are more people who are getting into the
Right.
postpartum studies to try to characterize what's going on. But I think part of it was that the conception that, hey, mom delivers and mom is fine. And so there was no interest in looking postpartum until, recent studies have showed that that's not the case. And another area that's really interesting is, we talked about women who develop preeclampsia in the early postpartum period, like they deliver, they had a normal pregnancy, 2 days after delivery, they develop these symptoms.
Yeah.
And then, or some of them may have seizures, postpartum eclampsia.
Yeah. It was on
And
Downton
so,
Abbey.
huh?
Nothing. It was just on a show that I used to watch.
Oh, okay. Yeah, it's like, why? And
Yeah.
what is different from these women,
Mm.
as opposed to those who develop it during pregnancy?
Mhm.
So there's a lot. And again, we could be thinking about too, after you deliver, there's a whole physiological response to get your body back, to pre-pregnancy state. So maybe these women are not able to, adapt.
Mhm.
It's so much that we don't know. And I think that's why I think this is such an interesting field. We welcome additional people.
Yeah, yeah. And what's so interesting too is that it looks like you have some areas of the brain that are, not as affected, maybe the hippocampus earlier on, but then later on, it looks like it's more affected.
So yeah, that's the
Right.
thing. So we have focused a lot on the short 2 months, 8 weeks after delivery. Now, a lot of our studies are going to look much later on to 8 months, 6 months, 12 months, 18 months after delivery. And we think during that time, we will see an exacerbated response. But at that 2 months time point, we're already seeing some changes. The question too that we have that I've always asked is it like a continuous process?
Yeah.
Do we have, there's this whole second hit phenomenon that something happens in the postpartum period that makes this women develop this thing? There's so many possibilities.
100%. Romina has a question, and when I'm going to take this opportunity to say Romina Garcia de Leon has a question. I'm going to just go get my Uber. Go to
Oh,
the
okay.
airport. But fantastic talk, and I look forward to. I will listen to the response of Romina's question.
All right. Thank you. Thank you so much. Okay,
Hi,
Romina, do
Dr.
you want to read?
Warrington.
Yes.
Yes, thank you so much for a wonderful talk. I actually just have a question. It's a little bit of a tricky one, I know, to get, but do you have any thoughts on perhaps why you saw more effects in the posterior cortical region in terms of your inflammatory cytokines as opposed to region like the hippocampus?
So at this point, I don't have any idea what's going on. I do know that the cortical region is a larger region. And it could be, I don't want to say it's a technical thing because we were able to get readings for I would say 90% of our cytokines on the kid in both regions. But I do know that, there's a larger posterior cortex as opposed to like a 16-gram one-sided hippocampus. So probably the starting material that we adjust for volume. It could be that maybe the hippocampal changes happen later on, and that the cortical regions are more susceptible. The white matter lesions do tend show that, the white matter is affected more than the gray matter. So it could just be, the composition of cells and composition of material in each of the regions. At this point, we don't know, but one of the ways that we can explore is to see, does it switch with time? And then to look at more targeted approach in different cortical regions. We did not look at any of the prefrontal cortex. We did not look, there are different parts of the cortex we have not looked at and considered. But that's something we can't fully explain.
Yes. Yes, thank you so much for that answer, though. It's helpful for my research too, because I see some weird things in the hippocampus too. So I'm like, okay, maybe I should be looking at the cortex.
Yes, oh, for sure. Because I mean, the cortex has important roles for memory as well, learning. So
yes,
that's where a lot of our memories are stored.
Thank you so much, Dr.
You're
Warrington.
welcome.
And I think with that, we are at time. So thank you again, Dr. Warrington, for joining us today. And thank you for everybody who attended. And I'll just close out today's seminar by inviting you again to check out our website, to check out the other seminars that are happening for the rest of the year, and register if you haven't already for those.